You can start.
كده تسمع. السلام عليكم.
عليكم السلام ورحمة الله.
تسمعوني؟
مساء الخير دكتورة. أي واضح الصوت.
مساء النور. طيب, this will be a review for some oral cases. We can start now if you like. It will include some long cases and some short cases or even spot diagnosis. We can start with an R4 for this case. Or R3, I mean a senior. I need someone to describe it as if in your in an exam. Usually, visual fields in exam, it's either a short case or part of a long scenario. So once you have this photo, just describe it quickly, and you can choose someone from seniors, Dr. Khalid.
If anyone would like to participate, عندنا الدكتورة دانيا تركستاني.
Okay. Anyone can, you can choose anyone.
الو السلام عليكم.
وعليكم السلام ورحمة الله.
كيف حالك دكتورة حنان؟
الحمد لله. كيف حالك؟ أهلا.
الحمد لله كويسة. طيب, so this is a visual field of the right eye. I can see first of all I have to check the data of the patient, the right correct name and age, and then the reliability indices, the false positive, negative, and the fixation losses. Here also all seems within normal limit. Then we have here in the map, we can see in the right eye there is a superior arcuate scotoma. Also, it's apparent in the pattern deviation. Regarding the pattern standard deviation, I cannot see the number, Doctor, really clear. Is it 8?
Yes, the pattern standard is 8. The mean deviation is minus 6.8.
Minus 6. So minus 6, this is like a moderate visual field loss.
Okay, so good description. It should be like that because you shouldn't take too much time during your oral exam for describing the visual field. So what's the description of this visual field you said?
Superior arcuate scotoma.
What's your differential diagnosis?
So differential diagnosis, since it's respecting the horizontal line, my top differential, it could be glaucomatous optic nerve damage. It could be any cause of retinal damage in the inferior retina, which affected by the superior part, or any optic nerve abnormality, which is unlikely to come with an arcuate. Usually it's altitudinal defect. Other things like excessive PRP comes with the visual field loss.
Okay. So this is a good differential. And what does GHT mean?
What?
You can see here, it's written GHT.
GHT? I'm not sure, doctor.
Okay, it's a glaucoma hemifield test. Do you know what does it test?
I think it's, I'm not sure, doctor. I forgot about that.
Okay, it tests some points from the superior and inferior field of the same
corresponding to each other.
Usually, yeah, corresponding points.
Yes.
And compare them. Usually, as you know, vertical field defects are related to neurological issues, but glaucoma affect usually one hemifield more than the other. So it will be the paper will give you the machine will give you outside normal limit as seen here, if it compares the points and they are unequal or asymmetric. Okay. So this is a short case. The differential diagnosis, as you said, glaucoma. You can have some more differential, including optic nerve pit. They can give some unpredictable visual field effect. So it might present as arcuate or similar to arcuate, even colobomas. Nerve fiber layer myelination depends on the extent of the myelination and the appearance. So just to have some differential. And as you said, retinal problems like BRA or branch retinal artery occlusion. Thank you, Dania.
Thank you, Doctor.
Excellent. Now we can go to the other case. We can go with a junior. Dr. Khalid, you can choose anyone raising the hand. Dr. Khalid? Anyone? Hello?
Anyone would like to participate? دكتور ركان العيسى.
Okay.
السلام عليكم.
وعليكم السلام ورحمة الله.
كيف حالك دكتورة؟
الحمد لله، كيف حالك؟
الله يسلمك.
So this case is a 55-year-old lady. She came to the ER complaining of severe pain and redness of the eye for 1 day. How to approach this case?
So this is the external photo of an eye showing mild
معلش خلينا نقاطعك بس. When the examiner asks you, okay.
You want to start with history, Doctora?
Yes, I just want to give you one point. If the examiner asks you to approach means you have to start by, or even treatment, or I mean management. If he asks you to manage the case, you will go by history, examination, investigation, and so on. Okay, so just be careful. Or sometimes if he asks you to describe and then approach, you might go back for the history. So in this case, we need to approach. You have the picture in front of you. You have some diagnosis or some thinking. Start.
I will ask first about the pain itself. Here mentioned is 1 day. I will ask if this is the first time or it's recurrent. The timing of the pain, is it worse at night or not? Is there any previous history of glaucoma? Any family history of glaucoma? Any history of trauma? Any previous history of use of steroids? Any history of using any medication like anti-glaucoma medication? History of previous surgeries? Systemic condition like diabetes, hypertension, bronchial asthma, renal diseases, sickle cell anemia, previous history of cardiac diseases. Also, we'll ask if she is allergic to any medication.
Excellent history. What else? You can ask about previous attacks of some pain or discomfort. You should ask about the other eye if she has any history in the other eye. You might add asking about antihistamines with the medications. Okay. Yes. Okay. Then you can describe and continue your examination.
So this is an external photo of an eye showing mild diffuse conj injection, mild corneal edema, shallow AC with looks like iris pompae peripherally. I would like to assess the cells or reaction in the anterior chamber. Also, I want to assess the lens and the disc. Also, we need to assess the visual acuity of the patient, the IOB, and we need to do gonio. And of course, examine the other eye.
Excellent. You missed one thing, which is the pupil.
Pupil, yeah.
Her pupil is fixed mid-dilated.
Mhm.
The cornea, as you mentioned, it's sorry. The cornea is a bit edematous. I'm not sure if it's clear. The IOP is 50, and the AC is shadow, as you said. The lens has NS1 only, and the gonio is shown here. Can you
Yeah.
describe it?
This is a gonio photo showing angle. The iris is covering the angle, so we cannot see the details of the angle.
Okay. So the disc is not seen as the cornea is edematous and the patient is in pain. What do you expect the disc to look like?
Usually, and I'm thinking about angle closure glaucoma. They usually they don't have any much disc damage.
Exactly. They might present with optic disc
Hyperemic,
edema.
yeah.
Yes, hyperemic edematous disc.
Yes.
There's something that you have to look for specifically. Other causes of angle closure. Now you have the provisional diagnosis as acute angle closure, but you didn't mention if you looked for secondary causes like NVIs, okay, neovascularization on the iris. So you should think about other differential as well to look
Yes.
for it during your examination. Okay, so how would you manage this case or treat this case?
So in the gonio, we need to do the dynamic gonioscopy to see if it's synechial or oppositional. Then we'll start the patient after asking about the other medical issues. We'll start the patient anti-glaucoma topicals like alpagan, timolol, 3 cycles, and if the renal function is okay, no history of sickle cell anemia, we can give oral Diamox 500 milligram once, and assist the patient after 1 hour for the IOP. If the IOP is decreasing less than 35, we can give, and the closure is oppositional, we can give pilocarpine to stretch the iris and do BI.
So the definite diagnosis for acute angle closure. Now this angle has a positional closure. So the definite treatment is the PI. You can give pilo. I think you just mentioned the pilo. So to prepare the patient for the PI, and how will you do the PI?
We give bio to stretch the iris. Then we'll choose the area which has a crypt because this is the thin area. Then with the Yagi laser, we can make the opening.
Okay. Do you know the power or anything?
We can start from 2 and go up till 6 till we can see gush of fluid coming from the aqueous.
What if you couldn't, the cornea was too edematous and the AC was too shallow and you couldn't do the YAG PI? Do you have other options?
We can try the argon laser.
What else? Other options? You couldn't do any laser PI.
We can decrease the IOB with the systemic medication like IV Diamox or Mannitol or glycerin.
Excellent. Excellent. And so sometimes the patient will not respond. I have some slides which are too busy just for review to have like summary slides on some cases. These are the risk factors for angle closure, just for your knowledge. Advanced age, females, Asians, family history. Sometimes they have precipitating events like being in dim illumination, dilating drops for other reasons like retina follow-up or something, other medications, including antihistamines or secondary angle closure related to topiramate or some or alsulfa medications. So one thing at the end of your case, you have to mention the other eye as well, because most of the cases are will have anatomically narrow angles in both eyes. So you have to check the other eye and do prophylactic PI as well. This is the mannitol dose, as you mentioned. You will give the mannitol in case he didn't respond. YAG settings and argon settings. One option, sometimes if the patient is really not responding or you couldn't do laser for any reason, you can go for surgical PI. Some books can mention those options. You can press on the center of the gonio just to push some fluid to the sides of the angle to open it a little bit if the IOP is really not responding and you couldn't do the PI. Some mention AC paracentesis, or if the pressure was too high and you couldn't lower it by any means, you can take the patient for surgical treatment immediately after trying the medical treatments, even the systemic ones. I think I gave you this slide before. It's just for a review, just not to be confused, that we have primary angle closure suspects where the IOP is normal, the patient is asymptomatic, and the optic nerve is normal structurally and functionally, but the angle is closed appositionally in at least 180 degrees. So those patients usually found incidentally, and they need prophylactic PI. Primary angle closure means that there is high IOP or peripheral anterior synechia, but the optic nerve is within normal. Okay, so they will need therapeutic PI. It's not prophylactic anymore because they have high IOP or previous attacks, which you can see by PAS. It indicates previous attacks maybe. So they need therapeutic PI. And then the primary angle closure glaucoma, where the optic nerve is affected. So that's why we're calling it glaucoma. There is high IOP or PAS plus structural or functional optic nerve changes. Those patients will need follow-up after PI to see if they will still need further treatment, medical, either by medical or surgical means, okay? I just mentioned this one because you will find it in books, not to be confused. Primary angle closure can present acutely, as in this case, or chronic, where the patient will have high IOP plus peripheral anterior synechia, or the patient might have intermittent attacks, either presenting as an acute attack or maybe subacute attack, not with the dramatic presentation of the acute one, or it will go into the chronic synechial closure. طيب, now this photo, I need anyone just to give me one word for this visual field. I brought it because they brought it to us in one of the oral exams, and they were expecting one word to describe this photo without giving any history, any visual acuity or anything. Who can tell me? Hello? سامعين صوتي؟
دكتور وليد السرحاني.
السلام عليكم على دكتورة.
أهلا كيف حالك؟
الله يحييك. So this visual field represents global depression with normal pattern deviation.
I need one word to describe it. Actually, this is the exact question which came to us in the oral exam.
So I would say this is a global depression.
Okay, any other suggestions?
Rule out media opacities or cataract. Because I can see the pattern deviation is normal compared to the mean field effect.
Actually, they were looking for the word absolute glaucoma. The visual field is, they didn't, they didn't discuss actually reliability or anything. It should be a reliable visual field. We don't know the visual acuity or anything. It's a like total visual field effect representing absolute glaucoma. Okay.
ممتاز.
شكرا. طيب. Anyone? نحاول نمشي أسرع شوية عشان يمدينا نلحق الباقي.
So I can participate in this picture.
Okay, you can go ahead. يعني هذه ما حتكون كيس طويلة مرة. I need you to describe and approach.
This is a disc photo of the right eye showing which seems to me a cupping around I would say 0.6, 0.7. Disc is normal in size. I can appreciate superior hemorrhage at the disc margin. What seems to be a myopic fundus.
Okay, excellent. So she's a 52-year-old lady presented to you for regular checkup. Would you ask, would you take more history?
I'd like to ask if there is any visual changes, any pain associated in the eye, any history of trauma, uveitis, any history of intraocular procedures.
Excellent.
Any family history of glaucoma, any steroid use, mainly to cover secondary glaucomas. This is mainly in the history, actually.
Okay. So regarding the examination, her anterior segment is within normal. The AC is deep. Gonio is open. IOP is 17.
I see.
Okay, and
I'd like to check in VA.
The rest of the fundus is within normal. No neovascularization anywhere.
I'd like to ask about any history of surgeries or refractive surgeries as well. I'd like to assess the corneal thickness, pachymetry.
Excellent.
Any history of migraine as well.
Excellent. What else? After migraine, you have to
assess visual field as well.
Raynaud's and
Raynaud's phenomena.
Yeah. Perfect. And the other eye.
Yes, and assess the other eye.
Okay. So then, what will you do after that?
As I mentioned, pachymetry, visual field, OCT of the nerve fiber layer.
Okay, so what is your provisional diagnosis? What are you thinking of?
There are disc changes with normal IOP, although I need to assess the corneal thickness, but most likely diagnosis on top of my differential is normal tension glaucoma.
Perfect. So you're reaching to my point, but you forgot some things. After I gave you the IOP and it's normal, you should put in mind that it could be some neurological disease. So you have to evaluate, you have to mention at least that you're evaluating the color vision and optic nerve for pallor.
I see.
Okay. Yes. So you should think, as long as the IOP is normal, this is the first visit, you should think about other differential of disc changes, including neurological issues. So what if you did all the investigations? Her corneal thickness is within the normal average. Visual field is unreliable. This is her first visual field, and have some non-specific changes, which is you couldn't take it into consideration because it's not reliable. How would you? What would you do to this patient?
We can start the patient on anti-glaucoma medication and give a follow-up to the patient. I assumed all the ancillary tests were normal, صح?
Yes.
The OCT, the...
Yes.
Yeah. I'm not sure about imaging, as you mentioned, in a neurological, as a neurological disease, but I would start the patient on anti-glaucoma, and then I will follow up the patient. I may start with beta blocker as a first line, asking about, of course, any history of asthma or any history of cardiac or vascular issues. But yeah, excluding the asthma and cardiac issues, we may proceed with beta blockers. The agent can be bitexolol as well.
Okay. How will you support your decision? Do you have any studies or anything supporting your decision?
As I recall, the normal tension glaucoma study, any reduce of the IOP, even if it's normal, within the normal range, can lower the progression of optic nerve damage.
Okay. Now we have an excellent approach. Actually, if the optic nerve has this appearance without the hemorrhages, I would prefer to observe initially, like 3 months, and repeat the other investigations, because it could be a history of glaucoma, especially if the patient has history of, for example, steroid use or previous uveitis. It could be a damage that happened at that time, and it's not progressing anymore. So you might wait in that case. But here we have some hemorrhages that are not explained by other reasons. No MVIs, she's not diabetic, no MVDs, or anything. So it could be. So the top of the differential is normal tension glaucoma. And usually the treatment is, as you said, reducing the IOP by 30%. Now, this busy slide is just for some definition and types and theories of normal tension glaucoma, just for you to review it later if you want. And the two types. Usually, if you will be examined by Professor, for example, he likes to ask about the two types, which is senile sclerotic and focal ischemic. You have to know that. And the evaluation, you mentioned everything perfectly, the IOP examination, gonioscopy. You have to stress on ruling out other causes like findings of trauma, findings of previous inflammation, and evaluation of the disc, ruling out pallor, for example. And regarding the imaging, you might go for imaging or be more keen to do MRI if the patient is younger than 40, if the visual field is more going with vertical midline, or there is some suspicious optic nerve pallor. Now, this is for you to know, just for some possibilities, some suggestions of non-glaucomatous disease if the patient has optic nerve pallor, if the color vision is decreased. Okay, And as you mentioned, to reduce the IOP, or observation initially if you're still not sure. This is the collaborative normal tension study, normal tension glaucoma study, if you'd like to review it, because I think you might be asked about some studies in the examination, especially the ones that are usually discussed in the clinic, like the normal tension glaucoma study. So this is the finding, is that lowering by 30% will decrease the progression. Okay, and factors for disease progression include the optic disc hemorrhage, low ocular perfusion, and migraine. Okay, excellent, Doctor. We
الله
need
يعطيك
some other participant. شكرا لك. طيب هنحاول نمشي أسرع شوية عشان عندي سلايدز كتير.
If
يعني
anyone would like to
if
participate,
anyone
raise
would
your
like
hand,
to
please.
participate. يعني to be quick, يعني just the important positives, important negatives in the exam, in the history and examination.
I'm going to choose if no one's raising their hand. دكتورة ديما جومر.
السلام عليكم.
عليكم السلام، كيف حالك؟
الحمد لله. أهلا دكتور.
تفضلي. Describe this photo.
Slit lamp photo of an eye that shows relatively quite conjunctiva, superiorly clear cornea and inferiorly multiple white capes. I would like to get which looks like a granulomatous. I would like to first take the visual acuity IOP for this patient. Check
okay, try not to jump to the examination. Now you described, you need some history. So the patient is a young patient, male. This is his first presentation with pain and redness for 2 days, for example. Okay. What would you like to take in history quickly? I mean the most important positives and negatives.
Okay, most important, I would want to ask about any previous, first associated ocular symptoms, any decrease in vision, ocular pain, redness, photophobia. Then I would ask about previous similar presentations, involvement of the other eye, if any presentation. Also previous medication or previous regime of treatment.
Okay. There's something important.
History of trauma or surgery, previous trauma or surgeries.
What else?
And associated also systemic symptoms.
Excellent. Systemic. So in uveitis, you shouldn't forget about the systemic associations. Okay. And proceeding to examination.
Okay, I'll start by first checking the visual acuity, the IOP, the corneal sensation. Then I would like to check the AC for any cells. And then I would like to have a dilated fundus exam to check if there is any fundus, posterior uveitic findings of the fundus. For sure, in this case, I can see it's suggestive of a granulomatous uveitis, so I would want mostly to look for signs of granulomatous, other granulomatous, associated granulomatous uveitis.
And the other eye, you shouldn't forget the other eye, and gonioscopy.
Yes.
So this patient, this is the first presentation for him. You can ignore the photo if it looks a bit pigmented or anything. I mean, the history is not related to this photo. He has uveitis for the first time. The IOP is high, like 45, and the angle is open. Posterior pole is within normal. Now, what's your differential diagnosis for this uveitis?
So uveitis entities.
Uveitis with high IOP, regardless the appearance of this photo.
Yeah, I think about herpetic keratouveitis. I think about Posner-Schlossman, Fuchs iridocyclitis, toxoplasmosis, and CMV endotheliitis.
Excellent. So how will you manage this case?
Okay, so do I have an established diagnosis by now or not yet?
Well, you have uveitis with high IOP, open angle. What will you do next?
Okay, so I would want to know exactly what entity is this.
So it means you will refer to the uveitis team.
Yes, if
Yes.
I'm not. So yeah, so now I'm a glaucoma specialist dealing with this case. That's what you.
Yes, we're in the glaucoma station, that's why. So just mention it to have more detailed diagnosis and evaluation of the uveitis.
With full uveitis workup to establish the diagnosis. Now, for me, I would first address the high IOP measure that he has. In this case, I need to first control the inflammation, and which is most likely what's going to decrease the IOP. And at the same time, I might also give some anti-glaucoma medications in the acute phase. So
what would you give medications?
Yeah.
Do you have options for medical treatment?
Yes, I can give start with beta blockers.
Assuming that the patient has no medical issues.
Sure. First, I would rule out any asthma or any bradycardia or any kidney or cardiac diseases.
Okay.
Mostly, I would start with beta blockers or an alpha agonist. I would surely avoid the prostaglandin analogs in case of uveitis.
What else would you avoid?
Also, pilocarpine is not preferable.
Excellent. So what's the mechanism of high IOP in these cases? This is the first presentation as a uveitis.
It's usually trabeculitis or it has multiple mechanisms actually. The uveitic glaucoma can be secondary to a couple of mechanisms. It might be due to like inflammation of the trabecular meshwork in cases of open angle. Then also in chronic cases, it might be secondary to PAS or peripheral anterior synechiae. And if the patient was on steroid treatment, then this can also be steroid like responder or steroid related high IOP.
Excellent. So usually this entity with the uveitis, acute uveitis with high IOP is related to trabeculitis, as you mentioned. And so I'm just, you can take this slide, it's just for a review. Those are the differential of high IOP in acute uveitis, because otherwise, usually acute presentation have low IOP related to ciliary body shutdown and hyposecretion. So the mechanism, as you said, excellent for uveitis in general, can be open angle or closed angle. And I don't think we have too much time to go through it. You mentioned most of it. And the treatment, you have to mention that controlled, as you mentioned. And we have medical treatment. And أنا سامعة صوتي دحين في صدى سامعة نفسي بس. Then you have to evaluate the patient and the indications of PI, including pupillary block and iris bombing. And if the patient is not responding or if he has permanent damage or chronic angle PAS angle closure, then you can go for surgical treatment. Now, in the surgical treatment, you have to control the inflammation at least 3 months pre-op, and it has to be combined with the uveitis team to evaluate the patient pre and post-op. The surgical options include deep sclerectomy if the angle is open. Otherwise, you can go for trab, or tube can be done as a primary surgery in uveitic cases. Risk factor for steroid response is primary open angle glaucoma, which could be not diagnosed before, diabetes, and high myopia. I need someone else. Hello? Any volunteer?
Anyone would like to participate, please raise your hand.
أيوة بسرعة خلينا عشان نخلص. It will be a short question.
طيب, I'll choose a resident. Or دكتورة ريما الأحمدي.
السلام عليكم.
عليكم السلام. Doctora, you have a patient, a young lady, was following you as juvenile open angle glaucoma. You put her previously on the Alphagan and Lumigan. Then she presented the next visit 2 months pregnant. What would you modify in her treatment?
I know Alphagan is category C medication.
Category B.
B.
It's the only category B medication, anti-glaucoma. So she's on Lumigan and Alphagan.
She can be on Timolol. You said Lumigan and...
You continue the Alphagan?
I will stop the Alphagan and put her on Timolol.
What about the Lumigan?
Lumigan is also, let's see. I honestly don't remember all the pregnancy related medication.
Okay, so Alphagan is the only category B medication, anti-glaucoma, which can be used. So we can use Alphagan from the early trimester till before delivery, just for the baby, because it might cross the placenta and affect the baby, and then it's contraindicated in lactation, during lactation. Regarding the prostaglandin, can be used later in pregnancy, but they are contraindicated in early pregnancy. So you have to stop the Lumigan. You can continue on Alphagan and see if she still needs medication. You can add beta blockers, but beta blockers as well has to be stopped before delivery, not to cause bradycardia of the baby. And it's better to avoid them during lactation as well, because of the bradycardia. But some mention that beta blocker can be used during lactation. So the main thing is to stop the Lumigan early in pregnancy. You can continue on Alphagan and beta blockers till before delivery. Okay. So this is day 1 post-trab. Who can participate? We can go quickly. This photo is showing a huge bleb. Okay, it's more dramatic than what appears in here. So how would you approach this case? Anyone?
الدكتور عبد الله الماطر.
السلام عليكم.
عليكم السلام.
Again, doctoral history.
نعم.
Again, the history you have mentioned.
The history. This is post trabeculectomy, day 1. The patient was patching the eye till he came to the clinic. We just opened the patch, and you can see a large bleb.
Yeah.
Okay.
Okay, so this is an external photo the eye, showing a conjunctival blib part. As you said, this is elevated. First, the conjunctiva is injected, elevated blib. I would like to check also with the VA. I would like to check an IOP to see if it's low. This would support overfiltering blib with such high blib.
What else would you like to see? So it's a low
AC chamber depth. It would be shallow in overfiltering blib. Would like to examine fundus to look for choroidal folds.
Excellent. What else?
And any leakage, although with this elevated, most likely it is there will be no leak. Disc, yeah. Would like to assess the disc along with the posterior pole.
Posterior pole looking forward.
Two things: the disc and the choroidal folds.
Choroidal folds. Okay. So he has low blib, high blib, low IOP. It's an overfiltration. Check for choroidals, hypotenuse maculopathy, or that's it.
Yeah.
So what would you do?
So first, we have the options. First, we have an anti-aqueous suppressant, mega BCL or a pressure patch.
Okay.
Steroid, we can decrease the frequency of steroid to allow for healing.
Yeah.
These are the main management.
Let's assume that there is peripheral iridocorneal touch.
We can start dilating cycloplegic like atropine.
Excellent. What if the lens is touching the cornea?
Again?
What if the lens is touching the cornea? The AC is flat with the lens touching the cornea.
This we can put the patient, send the patient back to the OR to reform the AC and maybe suture the blib with double suture or figure of 8.
Okay, excellent, Doctor. So other options that you didn't mention. If the AC is assuming that the AC is stable, no corneal lenticular touch, you can still observe sometimes, as you said, reducing the steroids, mega or large bandage contact lens, pressure patch. I just brought this one, so if you saw it in exam or anything, you should know it. It's a Simon shell. It's called Simon shell. It's the aim is to press on the blib. It's like applying pressure. This one is sutured to the ocular surface, and this one will cover the blib and it will press on it. Some other options, including autologous blood injection, and then surgical revision, especially if the cornea is touching the lens, you can go for it. شكرا دكتور يعطيك العافية. Spot diagnosis. This is day 1 post-trabeculectomy. Anyone? Just a spot diagnosis?
In the chat,
decompression retinopathy. Excellent. So what do you expect the IOP? You said it's decompression retinopathy. What do you expect, Dr. Khalid?
Answer in the chat. Low IOP.
Low IOP. It usually happens, I've seen it in young patients, more common than in old patients, after glaucoma surgery because of the decompression of the IOP. So usually we observe those cases and most of them will resolve spontaneously. If there's any cause of persistent hypotony post-op, then you should go for the treatment of the hypotony. Spot diagnosis, post-trabeculectomy.
Choroidal pulse, hypotony maculopathy.
Yes, hypotony maculopathy is the term. So what would you do for that? You should check for a reason for hypotony. Is it just post-op, or there is a leak, or overfiltration? What's the cause of hypotony? And you should treat the underlying cause if present, and observe. If it is prolonged with affecting vision for a long time, then you could revise the blib just to prevent hypotony. Day 1 post-deep sclerectomy. Anyone? Any resident? Anyone raising hand?
Walid.
Okay, Dr. Walid. How will you approach this case? She's day 1 post deep sclerectomy. The IOP is 30. You have this appearance of the eye.
Right. So in this case, with physical examination, I would start with looking at the blip, which looks flat and relatively vascular. And then I would look at the AC depth, to check if the AC is deep or shallow. And then I would do dilated fundus examination. And if there is no view, I would go for B-scan. And also do gonioscopy.
Okay, what would you look for in gonio?
In gonioscopy, I would look for internal block by either blood, fibrin, or iris.
Okay, it's a non-penetrating deep sclerectomy, so most likely you wouldn't. It wouldn't be blocked by blood or fibrin. Mostly, you should look for the iris. Maybe the patient had trauma or rubbing the eye.
Or iris incarceration.
It penetrated and the iris was incarcerated. Excellent. So the iris is clear. The window is clear. There is no iris incarceration. What would you do? Would you like to ask anything about the patient?
I would ask about the pain if the patient has significant pain.
Okay, it's important to know her condition, her baseline disc evaluation. Is it severe glaucoma or just mild to moderate? So what would you do for her?
My next step would be gonipuncture.
In the same day?
No, not the same day. I would observe, start anti-glaucoma to lower the IOP, and then consider gonipuncture.
Excellent. Would you consider massage in this case, day 1?
No, in cases of deep sclerectomy, massage is contraindicated because you don't want to open the trabeculodescent window.
Excellent. So that's why I just want you to know the baseline of the patient. If the IOP is acceptable, not too high, and the patient has a good disc, you might observe till doing the gonipuncture after a week. If the optic nerve is severely damaged and you're worried, you can start anti-glaucoma and bring the patient for gonipuncture. What laser is used for gonipuncture?
In cases of gonipuncture, I would go for gonipuncture.
What's the lens? Do you know what's the lens used?
It is the gonio lens.
Excellent. And do you know the power?
I'm not sure, but I think they start with with 1 millijoule.
Yeah, you can start with 2 to 5 is good. Q switched mode. Yeah, laser. Okay. You did the goniopuncture next visit, and the IOP didn't go down. Can you think of further steps?
So the next step, I would consider laser suture lysis.
Excellent. So by goniopuncture, you're almost converting it to trab, and the next step will be suture lysis. Excellent, دكتور يعطيك العافية. Next case. I need any resident, please. This is a 6-year-old boy referred to you from the pediatric ophthalmology clinic for IOP of 35. Can anyone describe?
دكتورة أسماء المهيزة.
تفضلي دكتورة.
أهلين هلا. So this is an external. You want me to approach or describe?
Describe the case and continue.
This is an external photo of an eye showing quiet conch, clear cornea. Cannot comment on the AC, but I see that the pupil is irregular, almost peaked, and I cannot see a lens. I think he is aphakic.
Excellent. So how would you manage this case? When they say manage, you should also start with the history.
He's 6 years old. I'd like to know first any previous ocular history, surgical interventions done for him, previous management. Why was he following up in PEDS clinic to begin with? Any history of trauma, maybe congenital cataract.
Yes, he's a case of congenital cataract, operated when he was 8 weeks old, and was following in the pediatrics.
And for history, I think this maybe I can move on to exam.
Okay.
For exam, I'll check VA, IOP, and then I want to assess the anterior chamber depth. And then, of course, fundus exam, focusing on the disc, and also the other eye, examine both eyes. If the IOP is high, I think my provisional diagnosis is aphakic glaucoma.
Excellent. And you can always ask for the central corneal thickness, especially in pediatrics, associated with either if the microcornea or congenital cataracts, they might have thick cornea.
I see.
Okay, so your provisional diagnosis is aphakic glaucoma. How would you treat the case?
We can start with anti-glaucoma medication.
What medications are you thinking of?
We can give prostaglandins. I think especially for his age, we want to avoid alpha-GAN. Otherwise, it is fine. As considering that he doesn't have any medical comorbidities.
Excellent. So to avoid alpha-GAN is the most important. And what if the patient has advanced cupping and uncontrolled on medical treatment? Do you know any surgical options preferred in aphakic glaucoma?
Not sure. Maybe I can't say really.
Okay.
Penetrating surgery or tube surgery, maybe, because he is already aphakic. Wouldn't work.
Yeah, in aphakia, they usually implants, tubes, are preferred. What's the mechanism or pathophysiology of glaucoma in aphakia?
I'm not sure. Maybe there is element of pupillary block.
Not really. If the vitreous was blocking the pupil, which is rare, which they usually doing anterior vitrectomy sometimes with the posterior capsulotomy. So, do you know other mechanisms?
Well, the anatomy is disorganized because there is no lens to maintain it. So maybe the angle is disorganized.
Okay, excellent.
Mm-hmm. And we already said that the vitreous will be blocking the trabecular meshwork. Maybe there is remaining. How long ago was the procedure done? If there is vitreous, viscoelastic used in the surgery.
No, it was a long time ago.
Okay.
Okay, excellent. So you mentioned the collapsed angle after the cataract removal. It could be trabecular dysgenesis as congenital anomalies. As the patient has abnormal lens, he might have abnormality in the trabecular meshwork as well.
I see.
They postulated also other theories like surgical induced inflammation. It could be related to the vitreous coming in contact with the trabecular meshwork. So excellent, Doctora, يعطيك العافية. It's just a summary slide for you if you would like to take it. Risk factors including cataract in the first year of life, as mentioned by the American Academy. Some say that the earlier the cataract surgery, the higher risk of glaucoma, especially if it was done before 4 weeks of age. The more complicated case, the more risk of glaucoma, and if the corneal diameter is small. This case, I think it's known to everyone, so we just need to review it quickly. Who would like to go? Would you like to continue, because it's 12?
Sure, no problem. So this is an external photo of an eye showing mostly quiet conj with clear cornea and aggressive neovascular iris neovascularization or Rebusus iridis, and mild cataractus changes. Approach-wise, history, I'd ask about any risk factors for ischemia like diabetic retinopathy, CRAO, CRVO, retinal detachments, and then about interventions that were done so far. For example, if he has retinopathy. Yeah, sure. Okay. And then if the patient was ever lasered or injected. This is as far as and of course thromboembolic risk factors, diabetes, hypertension. Moving on to exam, looking at the VA and IOP for both eyes. Then anterior segment exam will most likely concerned with the angle, if it is closed or open, so that we can classify or grade the patient for both eyes. And then it is important also to check the posterior pole to know the underlying cause, if it is, for example, diabetic retinopathy or ischemic CRVO or whatever that needs laser, PRP. This is as far as exam goes. Then
is high in this eye only. It's 56, let's say. And he was never seen before for any retinal treatment. The vision is 2200, and okay, the fundus is a bit hazy. You couldn't really evaluate, and the gonium was hazy also.
If there is no view to the fundus, we have to do B-scan to rule out posterior pole pathology, especially tumors, which can also cause NVG. And then what's the cause of the hazy media? Is it, for example, the face hemorrhage or?
He's diabetic, first of all, and he has some diabetic changes in the other eye as well, but no in the eyes. The cornea is hazy. He has NS. He has posterior subcapsular cataract.
So we'll start. Of course, this patient is for admission. We'll give anti-glaucoma meds, avoiding anything that aggravates inflammation. And then give Avastin injection if there is no view to the fundus, only as a temporizing measure to make sure that angle doesn't deteriorate.
Okay, let me stop you here just to tell you that anti-glaucoma plus usually you give Predford.
Cyclo and Predford.
Yes. Yes, and you refer the patient to the retina.
Yes, of course, so that they can do PRP as soon as the media clears.
Or
injections as initial management, intravitreal injection.
And then?
And then we'll go for if the IOP responds, and the angle, it depends if the angle is preserved or violated already. And
so then you will need to reevaluate after retina.
Yeah.
So if the angle is open, the MVA is regressed, NVI is regressed, and the angle is mostly open, what would you do? What would happen? I mean,
if the angle is, if the MVI is already regressed and the media clears, we can proceed with PRP.
I mean, glaucoma-wise.
Glaucoma-wise, we can do surgery if the IOP is not, if we're expecting more spikes, tube surgery mainly in NVG.
Okay. Usually, if the angle is open, the IOP might normalize after regression of the vessels, or might respond to topical treatments. The angle is closed, then you would consider the surgical treatment. It depends on two things: on the complete regression of the vessels and on the visual acuity and the other eye status. So if the other eye, if the visual acuity is good and there is a good visual potential, then you would go for either trab if the vessels are regressed, or tubes. If the visual potential is poor, the other eye is better than that, you can consider cyclodestructive surgery. There is one note that DS is contraindicated even if the angle is open and the vessels are regressed. Okay. And what if the pupil was blocked by severe inflammation? You should never do PI.
Because it will induce more inflammation and bleeding. Bleeding hyphema.
Thank you, Dr. يعطيك ألف عافية. شكرا. We can, I just put this for you to have the causes of the NVG. We can go for the next if you like. تبوا تكملوا معانا ولا وقف ولا كيف؟ الساعة 12:15 إيش رأيكم؟ في كم واحدة سريعة الآن أغلبها short cases. Any voting? Continue? Okay. So who will describe this case? This patient has underwent tube surgery 2 months back. His IOP is controlled. You gave him follow-up. And this is the appearance of the slit lamp. Anyone? دكتور خالد؟
دكتور عبد العزيز الشمراني.
ولا تبى تبدأ معايا؟
السلام عليكم.
وعليكم السلام. أهلا. Can you describe this photo?
So this is a slit lamp photo of an eye showing seems mildly injected conjunctiva. The slit beam shows, I'm not sure because the cornea is not clear for me here, but I can see a corneal edema maybe. And you see a superior tube in the anterior chamber. And the AC seems to be deep.
Excellent. Excellent. So as you mentioned, there is edema in the cornea, and the cornea is a bit hazy. The important negative that you should mention that you can't evaluate the location of the tube. Is it touching the cornea or is it away from the cornea? You have to mention that if it's not visible, if it's not clear in the photo. Okay, so the IOP was controlled and this is the photo. What would you do to the patient?
So in the clinical, after obtaining adequate history, I'm taking and you said the IOP is normal, take the BA and see the gonioscopy to localize the exact position of the tube. And I would like also to order specular microscopy for the endothelial cell count.
Excellent.
So to see, and if we have a pre-op baseline to compare how much was the normal endothelial cell count. The normal endothelial cell count is 0.6% per year, and if it is more than this, it means that the tube surgery should be revised for the endothelial cell count.
So what options do you have right now? You will observe. You will still observe.
Yeah, I'll do a baseline specular microscopy and I'll observe the patient. If the endothelial cell loss is high, so that I'll consider revising tube surgery. I also would like to start the patient, if the vision is affected, to start him in sodium chloride 5%, 4 times per day drops or ointment at bedtime.
Excellent. So you observed the patient, you gave him sodium chloride, and he came after 6 months with this photo, with this picture.
So he's definitely progressing and the edema is progressing. So I might consider surgical option of trimming the tube or reposition it away from the corneal endothelium.
Perfect. Thank you, Doctor. You were excellent. So as you said, it's recommended to have a baseline endothelial cell count for tubes, any type of tube, and especially if the patient has low endothelial cell count to start with, or decompensation in the other eye, or some guttata. So it's better to have a baseline endothelial cell count, and then it's better to put the tube as a preventive measures, to take the preventive measures of putting the tube away from the cornea. And if the patient was pseudophakic, you can consider placing it in the sulcus or even pars plana sometimes. And then you can start by observation and medical treatment. You can include some anti-inflammatory for the treatment as topical steroids. If the patient is progressing, then you should consider surgical repositioning or even removal of the tube. Day 1 post-trab, who can take over? نكمل؟
Dr. Mahmoud.
Okay, doctor. This patient is day 1 post-trabeculectomy. I'm just gonna give you a quick history so we can finish.
السلام عليكم.
وعليكم السلام، كيف
صوتي
حالك؟
واضح؟
صوتك واضح. I'm gonna give you the history so we can finish faster ولا تبغى؟ طيب, so he's day 1 post-trabeculectomy. The patient slept well. The eye was patched till today. We just opened the patch in the clinic, and you can see the photo. His vision is a bit reduced. His vision actually is dropped from the pre-op.
So we have to check the first of the visual acuity of the patient.
What's the striking feature you can see first?
Shallow AC.
Excellent.
I would like to check the blip, if there is leaking blip or over-filtering blip. I have to check the fundus exam. If there is no view, I have to do a B scan.
What to look for?
Look for choroidals, or like you have to rule out like aqueous misdirection, pupillary block, or suprachoroidal hemorrhage. So I have to do UBM as well to check the.
So
in this case,
yeah, you missed something very important. Actually, I'm waiting for the IOP.
Yeah, I told
you.
That, yeah, I'll check the VA, IOB, AC depth, and the blip.
Excellent. So his IOP is unrecordable.
Okay. Digitally?
Soft.
Okay.
What do you have in mind in differentials?
Maybe leak.
Excellent.
Or overfiltration.
Excellent. What else?
Maybe choroidals.
Excellent.
If there is severe pain, like I would suspect suprachoroidal hemorrhage. Pain out of proportion.
Usually present with low or high IOP?
Usually high IOP.
Yes.
with the subra, yeah.
So
But I mean,
for choroidal effusion.
yes, choroidal effusion.
Excellent. What else?
I mean, you mean the causes? Ciliary body shutdown.
Excellent. Yes.
Yeah, this is.
Two more. So we're talking about hypotony, day 1.
RD.
Right?
Yeah.
RD. And cleft. Cyclodialysis cleft.
Yes. Yeah. Cyclodialysis.
So, this is the differential of hypotony, day 1 overfiltration, leak, choroidal effusion, ciliary body shutdown, cyclodialysis cleft, and RD. So this patient has acceptable bleb, and this appearance of the fundus
Okay, so it looks like choroidal detachment. The examination. Serous choroidal detachment.
Perfect. Do you see any signs of
well, I'm seeing through my phone. It's not clear in my phone.
Okay, no problem. So how would you grade the shallow AC?
So the grading, this is I think grade 2, because there is a redocorneal touch without lenticular touch. If there is lenticular touch, I would label it as grade 3. Yes. Grade 1 is only the periphery with deep at the center.
Excellent. So this is the grading. Okay. So you saw it clinically. So as long as you can see it clinically, you don't need to ask for the V-scan. But if you couldn't view, you would ask for B-scan, and this is the appearance of choroidal effusion, where it's the echogenicity will be hypoechoic. The fluid will be hypoechoic in contrast to choroidal hemorrhage. Okay.
Yes.
Just wanted you to see the UBM of the peripheral choroidals. This fluid is this is the AC, the cornea and the iris, the ciliary body. There is no cleft. Yes. And this is the peripheral choroidals, or even ciliochoroidal effusion. Okay. So how would you manage this case?
Cycloplegics and steroids. So atropine would be a good option as cycloplegic. Observe the patient and frequent steroid, topical steroids.
Excellent. What if he is not improving?
Maybe intervene. We do like we call our retina colleagues to do drainage for the serous choroidal detachment, surgical drainage if like not improving.
Yes. So if it's persistent, especially if there is lenticular touch or starting PAS,
yes,
or the patient, yes, or if kissing choroidals, then you would consider drainage earlier. So this slide just to show you the risk factors for serous choroidal detachment, which includes increased age, scleral rigidity, as in non-ophthalmic patients or patients with short axial length, increased episcleral venous pressure, hypotony. Hypotony itself is a risk factor. If there is any cause of hypotony leading to choroidals, you should correct the underlying cause and postoperative inflammation. So what if you...
Doctor, I have a question, Doctora.
Sure.
Would you, in this case, as grade 2 AC dip, would you go and form the AC before يعني يكون في synechial formation?
No, you can observe. I would go for observation initially and follow up closely. If the patient is not improving with the atropine, then you might consider to reform the AC.
Okay.
Okay. Any more questions?
Thank you.
يعطيك العافية دكتور. شكرا جزيلا. For the sake of time, I just wanted to show you the difference between the choroidal hemorrhage and the effusion. This is the suprachoroidal hemorrhage in B-scan, where you can see the hyperechogenic fluid instead of hypoechoic. I think we discussed the suprachoroidal hemorrhage before, so this slide is for review if you'd like to take it, because I'm not gonna go through it right now. And the treatment. Okay, so who can go for this one? It's a quick case as well, because you discussed it with in previous CTRs, I think with other doctors. Anyone؟ تحبوا نكمل ولا وقت ما تبغوا توقفوا قولوا لي، أنا لسه عندي شوية slides.
Doctor, I think we'll have this as a last case, and then we'll have time for questions to end the session, if you don't mind.
Okay.
Anyone would like to participate, or should I choose? دكتور فراس مدني.
تفضل.
السلام عليكم.
وعليكم السلام ورحمة الله.
يعطيك العافية دكتور حنان، كيف حالك؟
الله يعافيك، كيف حالك؟
الحمد لله تمام. So you want me to describe?
Yes.
Sure. In the left picture, I see a clear media, a picture of a fundus, showing mainly the, I'm not sure if it's the right eye or the left eye, but the optic nerve margin is clear. The cup is around 0.2.
This one is a bit more than 0.2, 0.35 maybe.
0.3, okay.
Okay.
The color seems a little bit hyperemic, but I'm not sure if it's the picture itself or.
No, let's consider everything else is normal and it should be the right eye. What about the left eye?
The left eye shows large cupping, almost 0.8, I would say.
Mm-hmm.
There's also nasalization and bayoneting, notching.
Excellent. So it looks like a glaucomatous, right?
Yeah.
So this is a 60-year-old male, never been treated before for any ophthalmic issues, and he presented for decreased vision, gradual. He was seen elsewhere and they told him it's cataract. And this is his fundus appearance. Anterior segment examination is otherwise normal in the right eye, and this is the left eye. Give me the spot diagnosis or spot findings only.
Okay, this is anterior segment photo. Most striking feature is the dandruff on the pupil margin.
Excellent.
I would need also retroillumination. There might be also iris atrophy or multi-item.
Yes,
effects.
there could be some loss of pupillary rough right here. Do you appreciate it? Yes. Excellent. Otherwise, his examination is, the rest of the examination is normal. So one important thing you should ask about is dilation. Okay, this is the undilated photo. You just saw those dandruff-like material. When you dilated the patient, you saw this.
Yes.
What do you call it?
So this is a target sign or bullseye sign.
Excellent. So what's your diagnosis?
Most top different or diagnosis is the pseudoexfoliation. If he has a high IOP, I would say pseudoexfoliation glaucoma with the glaucomatous changes.
Yes. Excellent. So he has glaucomatous changes, so it's pseudoexfoliative glaucoma. So we'll go quickly. What do you need to look for in examination, other than the disc and the lens material? What else?
Okay, I will do complete exam, checking the vision, the IOP, the angle. I'll check the status of the lens, the iris. I'll see the AC, the fundus, of course, with the optic nerve, and also I'll check the other eye.
Perfect. So this is the classical appearance of the pseudoexfoliation glaucoma. Can you describe it quickly?
Okay, this is a gonioscopy picture showing mainly finding is the heavily pigmented tubercle meshwork and sample is 9.
Excellent. So it's an open angle, right? This is the trabecular.
It's an open angle, yes.
So it's an open angle. Okay. So regarding exfoliation glaucoma, I think you all know about. I just want you to give a brief treatment, the steps of treatment or treatment options.
Sure. We can start by topical anti-glaucoma.
Okay.
Usually, it's difficult to control the IOP as in comparison to other diagnoses like primary open angle glaucoma. So sometimes we might need to add from the beginning, depends on the IOP, of course.
Okay. Then
in case the IOP is not controlled, we can consider, of course, surgical treatment.
Yes.
We can do tube surgery or trab or other cyclo micropulse CPC.
Okay, so trab and deep collection of the angle is open, tubes are options, and then you can consider the cyclodestructive. Okay, I just want to stress on some points in the pseudo exfoliation. First of all, in this case, I brought like what's almost looking like unilateral glaucoma. So in your history, I'm sorry, I just I let you take the history very quickly, but because we're running out of time. But in examination, if they brought this photo, you have to think about unilateral glaucoma cases. You have to ask about trauma. You have to look for NVG, uveitis, previous surgery, or any previous treatment as treatment in one eye rather than the other eye. And uveitic glaucoma is one of the top differential for unilateral glaucoma. And then the examination is complete. Don't forget to dilate the pupil always after checking the gonioscopy. And in the history, you need to ask about systemic associations because it's a systemic disease.
Yes.
Can be associated with cardiac and renal or lung diseases. Can be found in association with the hearing loss, amyloidosis, Alzheimer's disease, CVA or other arterial problems. And you need to evaluate the cataract because it's recommended to go for earlier cataract extraction in those cases. And for evaluation of cataract, don't forget to do the endothelial cell count because they have higher risk for endothelial cell loss. Okay, and try to look for phacodonesis during your examination. And plus the dilation, you have to evaluate the dilation because they poorly dilate. Do you know why do they dilate poorly?
Because of the atrophy of the sphincter muscle.
Yes, the material can deposit on the muscles and on the blood vessels supplying the iris, so it can cause iris fibrosis and iris ischemia, so they don't dilate well. Okay, and
I also forgot the SLT, Doctor, for management.
The management, yes, it's a treatment option, medical, laser, and surgical treatment, excellent. And what else? You always have to observe the other eye because it's a bilateral asymmetric disease. So the patient might present with advanced cupping in one eye and with no apparent glaucoma in the other eye, but you have to follow up. شكرا دكتور فرانسي يعطيك العافية.
الله يعطيك العافية دكتور، شكرا لك.
الله يعافيك. So طيب تبغوا أوريكم بس الكيسز اللي بعدها تشوفوا شكلها يعني عشان spot diagnosis ولا تبغوا أسئلة؟ نروح للأسئلة. Yes please عبد الله الماطر. طيب this case is يعني might come for differential diagnosis and description. He's a child with central glaucoma, as you can see, with some neovascularization. So the differential diagnosis of CHED, you need of stump, stump, which is sclerocornea, trauma, and ulcers, and so on. The stump, you have to go through it, and then This case is Peter's anomaly. Peter's anomaly is, I think they might, it might present in the exam. So what you need to know is that Peter's anomaly is mainly sporadic, but can be autosomal recessive or dominant, sorry. The pathophysiology is defect or absence of the central decimate and endothelium, with two types, or three types actually, two types affecting the eye and one type called Peter plus. So type 1 is iridocorneal adhesion, type 2 is corneolenticular adhesion. How to evaluate or to differentiate between the two is by UBM. And Peters plus has systemic manifestation, so that's why you need to refer the baby for the pediatrician for systemic evaluation. How to approach? You need to examine everything as in congenital glaucoma and plus the systemic. You need to ask about take good history of perinatal and family history, and after that the IOP. Why? Because they might, because they have like more than 50% risk of developing glaucoma. So you need to follow them for the IOP. Treatment can start by medical treatment, and then you can go for surgical treatment if possible, but usually they have poor prognosis. Tube could be one of the options, or cyclodestructive surgery, and refer the patient for the anterior segment to evaluate the lens for cataract and the cornea for possible PKP. Next is, so this slide is for Peters if you'd like to see it, and differential diagnosis. Then traumatic hyphema is one of the important topics in the exam. In history, you have to ask about the age. Why? Because children might present with child abuse. You have to keep it in mind. And of course, the mechanism of trauma, you have to rule out other, you have to think about other trauma, signs of trauma before reaching to the examination. And one important thing is the sickle cell anemia. This is one of the most important things, and anticoagulants or clotting diseases. Then in examination, you have to look to rule out first ruptured globe. This is the most important thing, and then you have to evaluate the rest of the examination for signs of trauma, and you have to see the fundus for other signs of trauma like commotio, retina, and so on. Controlling the IOP is the most important. How to control it, medical, and you have to keep in mind the indication of AC washout. So you have too many indications. Usually I'm following the one in Wills, which is sickle cell anemia, IOP more than 24 for 24 hours. If the patient is pediatric age and you're worried about amblyopia, corneal blood staining, hyphema that doesn't decrease by 50% for 8 to 10 days, IOP more than 60 for more than 2 days, IOP more than 25 with total hyphema more than 5 days, because it has higher risk for stromal staining. 100% hyphema, uncontrolled IOP despite maximum treatment. That's it. So then it's an indication for AC washout. In AC washout, try not to pull on the clots, not to prevent rebleeding. Hyphema grading, usually grade 1 if it's below 1/3 of the AC, grade 2 from 1/3 to 1/2, grade 3 more than 1/2, grade 4 total hyphema. What's the mechanism of glaucoma in hyphema? Okay, so what's the mechanism? Either obstruction of the trabecular meshwork by RBCs or inflammation or fibrin, or direct injury to the trabecular meshwork. Okay, so that's those are the important points about traumatic hyphema. After that, you have to evaluate for angle recession. For sure, you have to mention that for re-evaluation after 4 weeks. for gonioscopy to rule out angle recession, angle recession. And if it's angle recession, you have to follow the patient because he might develop angle recession glaucoma at any time in his life. Okay. So I just wanted to show you the gonio lenses if you're still interested to continue. Shall I continue showing the rest of the slides? Okay, so عشان إذا جاتكم زي كده صور في الإكزام this is a direct gonio lens. Okay, you can just say direct gonio lens, or if you'd like to say Swan Jacob, one of the ones used commonly. Okay, and what about those lenses? Those are indirect indentation lens. Okay, indentation because the one for the other one is the Goldman. So this one, the first one is the Zeiss. This one it's written here, as you can see, it's the Posner, and this one is the Sussman. All of them are indentational lenses. Most of these lenses have a diameter less than 9 millimeters, so it can indent the cornea. What else? Okay, this case, I'm just gonna review it quickly. It's a 58-year-old female presenting with gradual decrease of vision. She doesn't have that significant pain, but she has history of pain before with where she sought medical advice. And there's something, according to her, some procedure was done. So today you saw the patient. She has some cataract with decreased vision, and she has patent PI with this appearance of the gonio lens. It's a closed angle, and when you press on the gonio lens, it's not opening. Most of the angle is synechially closed with deep AC in the center. Now this differential diagnosis, I brought it because it might be confusing. You have two differentials right now, either chronic angle closure glaucoma or secondary angle closure glaucoma. So usually in primary chronic angle closure glaucoma, the AC will be shallow and the angle is closed, as you can see here. But in other causes, like this one, you might think about plateau iris if the AC centrally is deep, and on gonioscopy you can see the double hump sign. So if you were suspicious, you're not, regarding those two differential diagnoses, you can do UBM. So the classical signs of plateau iris in UBM: obliteration of the ciliary sulcus, double hump sign even on gonioscopy, even on UBM, and anterior insertion of the ciliary body and iris itself. And you can see the ciliary body is too large in this case. So most of the cases have a large anteriorly placed ciliary body. So the point of this slide is that to show you that plateau iris can present as acute or chronic. So I think Dr. Ala Mufti presented an acute case where the patient presented with a picture of acute angle closure, then you did the PI, and then after that the patient didn't, the IOP didn't improve, and the AC was, the angle was still closed, and it was eventually diagnosed as plateau iris. In this case, it's a chronic angle closure. So just keep it in mind that plateau iris can present as a chronic and as well as acute. This is a congenital glaucoma. I think all of you are familiar with the congenital glaucoma. I don't have much to add. It's just for you to know. This differential diagnosis is always important to rule out other causes of tearing, if the patient was presenting with tearing, other causes of corneal opacity like the stumped differential diagnosis. And in history, don't forget to ask about the family history and perinatal history, because you have the forceps trauma, one of the differential diagnoses. Those are the findings. Usually, if the IOP is more than 21, is glaucoma, and some some people, I just wanted you to know that the range can, in the normal pediatrics, can be lower than in adults. So it can be normally from 6 to 15. And some people consider any higher IOP is a bit suspicious, even if it's not reaching to 21. And one more important thing is that you can examine the baby under milk sedation for 6 months, then chloral hydrate. You have to know that chloral hydrate doesn't affect the IOP. So that's why when we measure the IOP under chloral hydrate sedation, we don't expect that it's lower or higher, unlike the EUA. So what's the best time to check the IOP in EUA? Before intubation, or if you're just going for EUA without the surgery, you can examine the baby before he wakes up when they give the oxygen. This time can be very accurate. Then you have many surgical options. You have to mention the role of medication pre-op just to lower the IOP by the time you go to the surgery. You have to avoid alpha-GAN. You have to keep it in mind, and it's better to give beta blocker 0.25. The risk factors for failure is the more severe the glaucoma, presenting with more severe corneal haze or higher IOP, has a higher risk of failure. Corneal haze, you know the grading, and this quick one is showing late leak. The patient was operated like 6 years back, and this is the bleb. This is a cystic bleb with very thin avascular appearance. You have to check for leak, any signs of infection. She was presenting with pain and epiphora. So you have to check for leak, any signs of infection, as we said, and then I just gave you the enumeration of treatment options. You know, I don't think in the oral they will go deep in treatment of advanced. You know, this is advanced for you. I think they just need to know about options. You need to put the patient on antibiotics as long as he's leaking, and lubrication to prevent further rubbing of the eyelid and further enlargement of the wound. Then you have BCL or patch, which usually fail in late leak, and autologous blood is still an option in these cases, and most likely you will reach to bleb revision as long as it's avascular and cystic. Okay. This is the bleb encapsulation. Usually it happens early after surgery. So this patient was presenting like 4 weeks post-op. You can start by topical medication if the IOP was not controlled. As long as the bleb is elevated, you can see it elevated and localized. Those are the signs of bleb encapsulation. So you can go for needling with subconj MMC or 5FU in the clinic, or if the patient is early post-op, like 2 weeks post-op with flat bleb and high IOP, then you can go for massage and suture lysis. This is day 1 post-trab. Day 1 leaking is not like the delayed leak. So early leak can respond to other measures, conservative measures. You have to assess the depth of the AC, because if it's too shallow with iridocorneal touch, it's an emergency. If it's not, you can observe with other measures like decrease the steroid or withhold the aqueous suppressants, patching, mega BCL, gentamicin, autologous blood, and then surgical treatment. You have to advise the patient not to rub the eye or clean it, and keep prophylactic eye shield and antibiotics. If the leak was macro leaks are usually too big, more than 1 millimeter, and the AC will be collapsed usually with the macro leaks. So then it's a surgical treatment. This is a blebitis. You know the blebitis. I'm not going to go through it. I just brought this for Van Herrick because sometimes people get mental block in the exam and they show you this, what is this technique, and you can just say simply it's a Van Herk technique and this is the grading system. One more slide, I think this is the last one. You have to, this baby was presented for query high IOP. They measured the IOP in the oculoplasty or somewhere else in general ophthalmology clinic, and they were suspecting high IOP. They referred this baby for you. What do you think? Excellent, Dr. Walid Al-Sarhani, mashallah, Ghufran. So perfect. You have to describe and you have to ask for systemic manifestations examination. As long as you're suspecting that this is a plexiform, this is a classical S-shaped deformity of the eyelid. So you need to ask for signs of neurofibromatosis, 1, and do complete ocular examination, including the fundus exam for the optic nerve and the mechanism of glaucoma. So I just wanted you to know that the glaucoma can be related to infiltration of the angle itself. It could be developmental. So actually some studies say that it was reported that the baby presented with the appearance of like congenital glaucoma, and then later on he developed the signs of neurofibromatosis. So it could be related to developmental anomaly of the angle. Secondary angle closure of the ciliary body or choroid were infiltrated by neurofibromas, pushing the angle or pushing the iris forward, covering the angle, and fibrovascularization and endothelialization of the angle. So it's like anterior pulling mechanism of the glaucoma. What else? That's it. How to treat? Usually secondary glaucomas or glaucomas associated with systemic disease can be treated with with medication, unlike the congenital glaucoma. Congenital glaucoma, primary congenital, is usually a surgical treatment, but secondaries can respond to medications. So no need to rush for surgery if they ask you in the exam. This is day 1 post-Ahmed valve implant. You can see shallow AC. The AC is too shallow and the IOP is low. So it's a hypotony post-Ahmed valve. You have to check for leak. It could be peritubular leak. That will be obvious in exam probably if the conge is not closed well. It might leak clinically, or sometimes it might form a bleb anteriorly, which is not expected in Ahmed valve to have a high bleb anteriorly. Could indicate peritubular leak. So risk factors for hypotony, usually it happens in young age and myopics, and if the surgery was a primary surgery. What to do? You can observe. If the AC is shallow, you can always put the patient on cycloplegia. Treat any associations if there is shallow AC, as we said, with cycloplegia, or if there is choroidals, you can start him with steroids. And if needed, you can reform the AC with OVDs. You can, after that, you can revise the tube or remove the tube if it's not, if it's persistently hypotenuse. The tube can be blocked. Those are the post-tube complications, because we didn't discuss it before. The tube can be blocked by fibrin, by blood, and by vitreous sometimes if there is vitreous. And this case is blocked by blood, as you can see. It's too common in neovascular glaucoma. So what to do? You can increase the steroid frequency, topical TPA, or even intracameral TPA. Those are the tube complications. If you'd like to have some complications, just as enumeration. And I think this is the last slide. No, I'm sorry. This is edematous cornea superiorly. This patient is day 1 post DS. The IOP is controlled and the AC is deep. What do you think? It's not clear. It's an edematous cornea. So what to do? OCT, anterior segment, and you can see decimal detachment. So decimal detachment is one of the differential diagnoses of is one of the complications post deep sclerectomy. You have to keep it in mind in day one, especially if you can see significant corneal edema, because and the case was done as deep sclerectomy without phaco, you shouldn't have that significant edema. So you have to think about decimal detachment. What to do? Observe. You can treat as any decimal detachment after phaco or any procedure, air, eventually gas. They usually respond and you don't need to suture usually. Next case is phacomorphic. I don't think you need to go through this one. This is the UBM, can be helpful sometimes if you're not really sure. And this is the treatment. Of course, you have to control the IOP stat and start on steroids to decrease the inflammation and facilitate quietening of the eye so you can operate sooner. And then you can consider laser PI initially. Of course, B-scan, because usually there is no view with a dense cataract, and surgery. Usually they don't go deep in surgical options, but you have to keep in mind that you have two options. It's either cataract surgery alone, especially if the patient presented early. Usually they say within 2 weeks from the initial symptoms, or if you could see the gonio was clear and you could see areas of appositional, they will respond to cataract alone. If you can see the gonio and you could evaluate it, or even by UBM, it was clear that it is uniquely closed, or the patient was complaining for a long time, then it could be combined, or most likely you would need to combine it with a glaucoma surgery. That's it. When do you go for surgery? As soon as you quieten the eye and optimize the patient condition. You can always try to evaluate the visual prognosis, either by light projection, or you can project light with the colors, the color glasses, the red and green one, to see if the patient can see the colors. It indicates the intact macular function, or the PAM. Thank you. I'm sorry for taking too long. And يعطيكم ألف عافية. مرة آسفة إني طولت عليكم، الساعة صارت 1. I'm still willing to answer any questions.
الله يعطيك العافية دكتورة حنان، ما قصرتي أبدا.
الله يعافيك. إيش بيقولوا، في أسئلة ولا حاجة؟
Organized review. I'd like to ask the audience if they have any questions. Please, you can unmute your mic or you can write it in the chat.
Yes.
السلام عليكم.
وعليكم السلام. بروف عصام.
دكتورة حنان،
كيف حالك بروف؟
ما شاء الله. انت كده ما سبت لنا حاجة يعني you finish everything تقريبا
بروف، ما نستغنى عن رأيك في to evaluate
ما شاء الله very nice presentations و cases you present to the resident to their level is excellent. I appreciate. بس أنا ليا كومنت بس في حاجتين بسيطين جدا.
اتفضل.
بالنسبة للياج ليزر احنا نسميها انرجي، ما نسميه باور. وبالنسبة للحالة اللي عرضتيها الفيرست داي بوست اوب ليك او اوفر فلتريشن، فالاوتولوجاس cannot be given for early. It can be given only for late treatment, not early. لما يكون في ليك ما ندي اوتولوجاس بلاد في الايرلي ليك، ندي ليت بس في الليت بليبليك. الايرلي ليك you can treat as you mentioned decrease steroid, you can give gentamicin to irritate the bleb, you can observe and provide the anterior chamber is deep. انما ما ندي autologous blood injection. But ما شاء الله you cover everything almost. خلاص ما فيش place for us to discuss with the resident anything.
لا بالعكس بروف، يعطيك العافية.
تسلمي الله يبارك فيك.
شكرا على حضورك.
الله يحفظك، تقبل الله منا ومنكم صالح الأعمال.
آمين يا رب. شكرا.
السلام عليكم.
وعليكم السلام. One question in hypotony after bleb in hyperfiltration. Giving steroid will elevate IOP, but doesn't take about 10 days to ماني فاهمة. Doesn't take 10 days to elevate IOP, and in the meanwhile it will prevent fibrosis, which is what we want. I'm not sure if I get your point, دكتورة غفران.
السلام عليكم دكتورة.
وعليكم السلام، أهلين.
الله يعافيك. My question is إذا صار عندنا hypotony والhypotony هذا is because of overfiltration. إذا صار عندنا suprachoroidal effusion. Giving steroid it will هذا المانجمنت إنه we give steroid we give atropine. elevation of the IOP it will take time صح؟ يعني حتى عندنا steroid responder وهذا الأشياء steroid will take time to build the IOP. And this time الفايبروسيس will be delayed what we want. إحنا نبغى يصير في fibrosis حق البلب. فأحس two mechanisms are contradicting each other. What do you think about it?
Usually لو كان overfiltration you decrease the even if it's associated with the choroidals, you can decrease the steroid to promote fibrosis. And decreasing the overfiltration will increase the IOP and treat the choroidals.
تمام اوكي واضح يعطيك العافية.
ايوه ماذا يعني is it clear?
Yes it is clear. Thank you.
يعطيك العافية شكرا. Is there a specific time or duration for sclerotomies in cases of choroidal effusion not responding to medical? Usually kissing choroidals has to be managed early within 24 to 48 hours, even if it's serous, because adhesions might happen between the retina. If there is no kissing choroidals and if it's hemorrhagic, they wait for blood ايش يسموه liquefaction. Yes شكرا. For blood liquefaction for 7 to 10 days. In choroidal effusion you can wait more. Usually you can evaluate the patient if he's improving. If there are signs of improvement you don't need to rush in. Unless there are no improvement, the vision is affected, then you can go. I don't know a specific time for that actually. I'm not sure. أيوة يعني ال indications لو كان ال AC is too shallow, not getting better, or if it's grade 3 lenticular corneal touch, or the vision is poor because the choroids are affecting the vision, or there is no any sign of improvement after giving the medical treatment and waiting, observing the patient, and he's not improving for a long time. Any more questions?
I think by this we can conclude دكتورة the session. الله يعطيك العافية ما قصرتي. Very informative and an amazing lecture صراحة مرة استفدنا.
الله يعافيكم. أتمنى تكون يعني فعلا غطت أكثر الأشياء اللي حتجيكم في الاختبار.
والله زي ما قال البروف ما شاء الله ما خليتي شيء. الله يعطيك العافية.
الله يعافيكم يا رب. شكرا على حضوركم. I appreciate it and I'm always happy to answer any question at any time.
ما تقصرين. يعطيكم العافية جميعا على الحضور وبالتوفيق وتقبل الله منا ومنكم.
شكرا. الحين أعمل stop sharing وإيش أسوي بعدها؟
لا I will handle it خلاص. I will end.
Okay. شكرا.
Thank you very much.